Welcome to the e-learning module on inflammatory bowel disease. In this video, we will learn about gross and microscopy of Crohn's disease, which is also called as regional enteritis. The learning objectives are to know the gross features of Crohn's disease and to know the microscopy of Crohn's disease. Crohn's disease, which is also called as regional enteritis, usually affects any portion of GIT from mouth to anus. But most common involvement is terminal ileum and cecum. And it is characterized by presence of transmural non-caseating granulomatous inflammation. The common site is terminal ileum, 15 to 25 centimeters of terminal ileum, which may extend to cecum or ascending colon. The earliest gross lesions are aphthous ulcer, which are very small, minute ulcer involving only the epithelium, which are visible macroscopically scattered throughout the extensive portion of otherwise normal bowel. Later, they will coalesce to form large ulcers. You can see multiple separate, sharply delineated areas of disease with intervening uninvolved areas. So this is called as skip lesion, presence of delineated areas of affected lesions with intervening uninvolved areas. The wall of affected bowel is thickened and hard, leading to the appearance called as horse pipe appearance. The serosa will be studded with minute granulomas and mesenteric fat will extend around the entire serosal surface, which is called as creeping fat. The lumen will be narrowed. Mucosa, you can see various kind of lesions. The most important ones are elongated serpentine ulcers, which are oriented along the long axis of the bowel, called as serpiginous ulcers. Then there is intervening surviving mucosa, which is swollen, and there is diseased mucosa, which is depressed below the edematous normal mucosa. This will lead to the appearance called as cobblestone appearance. You can also see deep fissures. So grossly, you can see the alternate areas of involved and uninvolved areas called as skip lesions. Usually it will affect terminal ileum and part of the cecum. Then there are longitudinal ulcer called as serpiginous ulcer and affected area with adjacent edematous elevated mucosa, which will lead to the appearance called as cobblestone appearance. So in this picture, you can see the lumen of the affected part, which is terminal ileum, is very narrowed. And you can also see the thickening of the bowel wall. And here you can see narrowing of the lumen leading to stricture. In this picture, you can see presence of fissure. You can see the affected area which is having stricture and also unaffected area leading to the lesion which are called as skip lesions. In this picture, you can see the longitudinal ulcer, narrow ulcer, which are called as serpiginous ulcer. In this gross picture, you can see the cobblestone appearance. It is because of the affected area which is depressed, whereas the normal area will be elevated because of edema in the mucosa. This appearance is called as cobblestone appearance. In this picture, you can see the extension of the mesenteric fat throughout or surrounding the serosa, entire serosa, which is called as creeping of fat. Coming to the microscopy, there is transmural inflammatory cell infiltrate, predominantly lymphocytes, plasma cells, macrophages. So these are chronic inflammatory cells. And in 35% of the cases, you can see non-caseating sarcoid-like granulomas. There will be patchy ulceration, which are having deep fissure And also there will be inflammatory infiltrate, predominantly lymphocytes and plasma cells. There is widening of the submucosa because of edema and also increased lymphoid aggregates. In chronic cases, you can see the wall fibrosis. So here you can see there is inflammation in the bowel wall. The crypts are having inflammatory infiltrate, neutrophils, which is called as cryptitis. If there is accumulation of these neutrophils within the lumen, means it is called as crypts abscess. Then there are sarcoid-like non-caseating granulomas having epithelioid cells. Then there is deep ulceration leading to fissure. There are transmural chronic inflammatory cell infiltrate consisting of lymphocytes, plasma cells, and macrophages. So here you can see the muscularis propria of the large intestine, which is also showing chronic inflammatory cells. So here you can see in this picture, there is a deep fissure. There is increased lymphoid aggregates in the submucosa, and also in the mucosa, there are small ulcerations as well. In this picture, you can see the crypt distortion. There are lymphoid aggregates throughout the wall, here also in the subserosa. Here you can see multiple epithelioid cell granulomas affecting the muscularis also. So this is the picture where you can see non-caseating granuloma highlighted by arrow. So to brief, on gross, there is narrowing of the lumen in the affected area and alternate areas of affected and unaffected area, which are called as skip lesions. The wall will be thickened and you can see minute granuloma on the serosa. They can be stricture, they can be abscess formation, they can be fissure and also fistula, connecting the part of the intestine to the adjacent intestine or any other abdominal organs. There are longitudinal ulcer, which are called as serpiginous ulcer, and because of alternate areas of depressed and elevated normal mucosa, there is cobblestone appearance. And on microscopy, you can see increased lymphoid aggregates in the wall, which is transmural. And also in 35% of the cases, you can see characteristic sarcoid-like non-caseating granulomas. So the important feature is the inflammation here is transmural. Thank you.